Hi, my name is Dr. Bhavsar, and you're watching MedReader. Today, I want to discuss about osteoporosis, not just the pathology or the how the disease progresses, basically, but more on the management side, clinical pathways for first-line failure, and how to escalate therapy if things go wrong. Because you can have patients be on bisphosphonates for years, to be honest, but you're going to have to change something at some point if the results are, not favorable. So let's start with a question. So imagine you have this board question where a 74-year-old female is presenting to your clinic with a follow-up for her osteoporosis. You started them on alendronate 6 months ago, and their DEXA revealed a score of minus 3.8. Despite strict adherence to the medications confirmed by their family members or the person who's living with, she still has, not she today is presenting with a mid back pain. Now, imaging has a pathologic wedge fracture. She is on the alendronate therapy that you prescribed for 6 months, and a workup for a secondary cause, including high PTH or multiple myeloma, is negative. What is going to be our next step? Think about it, pause it, and think about it, and we'll move to the next slide. So the answer to this is to switch to Teriparatide therapy, which is a PTH analog. This person has a severe osteoporosis characterized by a T-score of less than 3.5, and she experienced fragility fracture. So this is medication failure, and you have to move to the next best choice. Now, why Teriparatide, and how will you manage the condition moving forward if this one fails? We'll talk about that in next slides. All right, so this is a quick timeline that we discussed in the previous question. At 6 month or 6 month to 12 month is your window where you reassess and see if things progress in a wrong way, decrease in bone mineral density, or having a pathologic fracture on bisphosphonate. You need to reassess the treatment at that point. So remember, 6 to 12 month will be a clinical vignette in your question on your boards. And always remember two distinct clinical scenarios when you are dealing with an osteoporosis patient, whether you pick one therapy or the other. If their baseline first time diagnosis is severe osteoporosis, how severe osteoporosis? Your T score is less than 3.5. Or with a score of less than 2.5, they're having a pathologic fractures right now. So they're starting severe. You can consider to start them on teriparatide if this is the presentation. If they have progressive bone loss, as you prescribed alendronate, and over time they have progressive bone loss, then you can switch to the anabolic therapy, teriparatide, which is a PTH analog in that case. Two scenarios. If they're starting severe, you can start teriparatide in the first place. Now, before you switch therapies, you always have to remember that you screen for the underlying secondary causes that can lead up to presentations like this. Hyperthyroidism, it's just an increased bone turnover. Your bones get porous with that. Hyperparathyroidism, which is essentially high PTH consistently and causing bone loss. Malabsorption, low vitamin D, low calcium, issues with that. CKD, the phosphate system is off. Calcium reabsorption is down because of the less active form of vitamin D present. Liver disease, multiple myeloma for obvious reasons. Exclude all these pathologies and then only consider treatment failure. All right, so this diagram quickly explains at what decrease in bone mineral density level, or if at all, there's presence of fragility fracture, which will change your treatment course. So if you have a bone mineral density decrease on a follow-up 6 month or 12-month DEXA scan, and that density loss is less than 5% or within 5%, you just continue the same treatment. That's not any meaningful drop, and this treatment still needs more time to show effect. But if the bone mineral density is decreased by 5% or more, you can consider switching at that point. It's like a shared decision making. But if they have a fragility fracture on this treatment, it clearly doesn't work, and now there's harm. So you need to change it to either PTH analog or denosumab, which is a monoclonal antibody that works with the rank L receptors, as you know, but it's a more expensive option, and if they have any side effects from the other treatment, they can use this. But it's commonly used these days. So, quick slide on teriparatide and its anabolic mechanism. It's a recombinant PTH analog. Remember that it's a pulsatile effect that you produce with daily sub-Q shots. So you give PTH and then there's no PTH for a while, and that's how it causes, in general, more favorable bone remodeling, because you need some sort of PTH stimulation to break the cortices and then form it more. That's how these medicines work. So patients with severe osteoporosis or those who fail the first line treatment in boards, you can pick this option as a more favorable one if you have a case of bisphosphonate failure. And remember, it's a daily sub-Q injection. The duration for someone to be on PTH treatment is 2 years. Okay, so this is a quick duration timeline of the treatment bridge we discussed. You started with a PTH analog, you continue it for 2 years, but after that, it's a sequential requirement that after that 2-year treatment with the PTH analog, they must be resumed on bisphosphonate. In some cases, you might see that someone who was on a chronic glucocorticoid therapy for any autoimmune disease or anything, now they stopped that therapy and they had some osteoporosis, but they stopped the glucocorticoid therapy. Now you can potentially, stop your osteoporosis treatment because the cause is gone. But do not use it concurrently with bisphosphonate. PTH analogs or bisphosphonate as a first line. Don't do it together. Might as well switch to other forms like denosumab at that point. Okay, so a quick run through on what we discussed. For board purposes, you're gonna have a question saying, a simple question like which treatment to start in the first place. If it's a mild osteoporosis, you started with bisphosphonates. And when do you reassess? It's a 6 to 12 month window. What happens if you have a fragility, one event of fragility fracture in that window? You still continue the therapy because 6 to 12 months are needed to see that change. What if there's progression of DEXA at more than 12 months? Then you screen first for the secondary causes, endocrine, renal, hepatic, malignancy, multiple myeloma. We discussed all that. And then you escalate based on these thresholds. Bone mineral density, if there's more than 5% drop, you change or you change to PTH or you escalate therapy from bisphosphonate. 2 years is the max for that treatment, and you stop at 2 years and then you resume and put back on bisphosphonates. And you continue your usual DEXA scanning. I hope this video was helpful, and I will see you on the next one.